So hi again. Yes, it's me again. I'm going to be talking you through kind of clinical case studies, and this is really it's a way that I can demonstrate kind of what we do on a day-to-day basis with all of our patients. And these are a couple of cases that I've utilized in my recent supervision, going through with Abby in terms of looking at the case that was involved, but also looking at kind of how my thought process worked in terms of working out differential diagnosis. And this is kind of hopefully a way that we can work through it and you can get a bit of a picture to see kind of what we do on the shop floor. So I've got three presentations. I've got one is a presentation of an APH, one was a presentation of preeclampsia and the treatment of hypertension, and one was a specific, like non-specific presentation for abdominal pain. So hopefully we can talk through kind of all the different ways that we can review these patients utilizing the skills that we have gained during our training, because a lot of these skills when you go onto the ACP course, you'll either do a history taking and a kind of assessment practice course. Mine was called Happy, and it does not make you very happy. I'm just putting it out there, but it is a really good course in terms of teaching you how to elicit that information from the patients, really going doing that deep dive of that patient, but also utilizing consultation methods to gather that data and kind of stream that information that patient's giving you, and then working through that differential diagnosis and those skills to do that in terms of assessing that patient effectively to get the answers going through. So hopefully case study one is the APH. I'll give you a little bit of a clinical presentation, the background behind her. She was a primate, but she attended the triage department in her 24th week of pregnancy. She had a sudden onset of fresh bleeding on underwear and on wiping. There was no reported abdominal pain, and her fetal movements were reported as a normal pattern. The ABCDE was undertaken to assess obviously maternal well-being. The airway was patent. She was talking normal length sentences. Breathing was no normal respiratory effort. Circulation was normal. The radial pulse was present, which regular 88 beats per minute. Blood pressure was normal. Skin was warm and perfused. Disability was good. So in terms of her, she was A on AVPU. And on exposure, there was no obvious significant ongoing APH. Her current ST pad was clean with no fresh bleeding seen. So that initial assessment that was done by the midwives in triage and also by myself when I went to see her kind of gave us that there's no immediate signs of any kind of placental abruption, maternal sepsis, and therefore she was a yellow score on her BSOTs, and we had to see within an hour. So this lady, she had a BMI of 37. She was, I think, 24 years of age, generally fit and well. There was no mobility issues. She was a smoker, but there's no illicit drug misuse. And generally, she was fit and well, no known allergies, no social service input. Although she did have some medication, she was using lactulose for a bit of constipation. There was no other medication that was being utilized. There was, however, family history. Her mother had CN1 cervical cancer, and then she also had a late onset hypertension, and a maternal grandmother had bowel cancer. But in terms of the other family history, there's nothing else relating to this pregnancy. So, undertaking a systematic review, and these are done very quickly in terms of when you're assessing patients. So generally you're seeing them, how they're coming into the unit, how they dressed, how they're looking, are they accompanied with anyone. She was coordinated, so she wasn't feeling dizzy or unwell. There was nothing to note with the glands, no kind of ENT history, respiratories, no history of any asthma. There's no chest deformities that you could see or any previous surgery. You're looking through the cardiovascular history. There's nothing that there was to note from that particular patient. There's no family history of cardiac disease. Abdominal history, she had no history of any surgery or hernias. There was no history of IBS, lupus, diverticular disease. There's no history of kind of MSK, so she was generally a fit and well patient. She did have swabs in early pregnancy, which were all negative, showing so no signs of any kind of infections like chlamydia, gonorrhea, and there was no history of any UTIs that she'd had so far in this pregnancy or out of pregnancy. No history of fibroid cysts. She had no smear history as she was under 25, so she hadn't yet started that kind of process, but there was family history of cervical cancer, and obviously no past history of STIs either, so nothing in the past. So that was a general systematic review that you kind of go through top to toe just to see if there's anything that's particularly concerning for this patient that you may have to consider in terms of a diagnosis or a potential cause. So her presenting complaint, I tend to use old CART. There are different systems that you can use in terms of PQRST or Socrates, but this one tends to fit for me, and there's lots of different things that you can look at. So if you are going to be going down the ACP route, they will be talking to you about your consultation models. But this, particularly for me, in Triage works very, very well. It's easy to remember, but also it's a good format to utilize when you kind of drill down the information that they're giving you. So is for onset. And there was a sudden onset of unprovoked fresh bleeding, and that was less than 50 mils in her underwear and on wiping. The location, obviously, she thought was vaginal bleeding. There was no report of any rectal bleeding and no report of vaginal abdominal trauma. The duration of it, so this fresh bleeding lasted for 20 minutes, then it settled to a brown loss on wiping. And then the characteristics, this is kind of really where you can dive into it in terms of finding out that kind of finer detail. There was fresh red blood loss, there was no clots, it was painless, there was no rupture membrane report and no abnormal discharge. You can also kind of elaborate in this in terms of asking about fetal movements, abdominal pains, any other kind of issues that might be characterized with this onset. Was there any aggravating factors? So looking at, was there any intercourse, constipation? And she was reporting that when she's often constipated, she may sometimes increase a bit of bleeding. And occasionally when she does gym exercises, she can have a little bit of breakthrough bleeding as well. Relieving factors, so obviously she's improving her constipation with using her lactulose and abstaining from some intercourse because that seems to be a triggering factor for her in this pregnancy. And obviously we can tell she's had lactose for her constipation. So it kind of gives you an ability to drive into that information that she's given you to kind of guide you in terms of where you're going to go with your next kind of examinations. So we know from the ABCDE that her observations were settled and stable, that she was in no immediate danger. She had a CR reading of 12, which was, although high, she was a known smoker. So she would have had additional kind of information about smoking and pregnancy. And the fetal observations were fine. The sonicate had the baby's heart rate 130 beats per minute. Obviously, she was too early for a CTG, and the fetal movements were being felt by the mum. And there was no palpable tightenings and no reported tightenings from the mother. So we then move on to a system examination. So we've got that history in terms of how it started, what she's come in with, her history of her background. And now we're working through the systems that we want to kind of elicit a little bit more information from. So we're looking at the abdominal examination. So she had a normal fundal height for gestation. It was soft and non-tender to palpate. So that immediately hands-on tells me there's not an immediate abruption potentially happening here. So that's reassurance enough. Urine dipstick, that was negative. So that was reassuring in terms of looking at other causes. There was no scar seen on her tummy. There was no umbilical hernia or inguinal hernias. And when she was asked to cough, we couldn't see anything that was exciting from that perspective. On light palpation demonstrates no tenderness. We kind of lightly palpate the 4 quadrants of the abdomen, and then you do a bit more of a deeper palpation, the 9 segments, which indicates similar findings to light palpation, with the patient being comfortable throughout this examination. There was no Garden, no rebound tenderness. There was negative McBurney's testing and negative Murphy's sign. And there were normal bowel sounds, and there was no masses felt apart from the little baby that was in the abdomen. So urinary tract, obviously urine was clear and negative on testing. There was no report of any vaginal discharge or odour, no history of STIs. Speculum then was undertaken with consent. Externally, no visible trauma, no FGM noted, and no vulvar varicosities. There was no rectal bleeding as well that we could see either. Her cervix was posterior, normal. Cervix appearance was normal, no obvious cervical changes, and no ectropions were evident or that we could see. The os appeared closed. However, within the middle of the os, there was a soft, mobile, painless kind of cerebriform mass, and it was protruding through the cervix. And it was quite a moderate size. It kind of appeared to be about 2 or 3 centimeters in size. And you could see the little stalk that was kind of attached to the polyp coming through the cervix. During the speculum, obviously, looking at the polyp, and when it was agitated from the speculum, there was a little bit of fresh bleeding seen. There was no clots and no other cause identified for the vaginal bleeding. So this kind of chart is my brain splurge on a page in terms of looking at all the possible diagnoses and the differential diagnosis for this patient, to make sure that I'm asking myself the right questions throughout his examination. You know, have I ruled this out enough that I can move on to the next bit? So we were looking at miscarriage and threatened preterm labour. There was a history of sudden onset of bleeding at 24 weeks, so there's potential that it could be. Her obs was stable, the bleeding has settled, there was no pain, and the speculum showed really no ongoing kind of bleeding seen outside the blood loss from the polyp, and the os was closed. So features of the evidence of that diagnosis: the os was closed, no ongoing bleeding, there was a polyp seen. We did take an HVS just in case there was an infection as well, but at that point in time we could probably put aside the risk of that as quite low. The next point was a potential for it to be a low-lying placenta. You know, at that point we hadn't actually discussed where the placenta was lying. There was an onset of this bleeding. A scan at 20 weeks indicated the placenta was low, but it wasn't covering the os. So further scans were requested to ensure the placenta, you know, hadn't been misdiagnosed, but also that it's not an ongoing concern. So we could then rule that out. Cervical changes, cancers or abnormal findings. Obviously, this is a bit of a concern with her family history of cancer. And obviously that sudden onset of bleeding, bleeding after intercourse, bleeding after constipation, and breakthrough bleeding when not pregnant. But there was no significant weight loss. So we did the speculum, obviously the cervix was normal, there was no ectropions, but we did, however, see that large polyp with the stalk. This was the probable diagnosis of the cause of bleeding, as we had seen it when we agitated it. But also, we now need to think about ruling out other signs of infection, STIs. We knew that from her booking, she didn't have anything currently, but ultimately it's worth making sure that there was no evidence of any kind of abnormal odour, discharge, warts or growth seen, and we took the HVS at that point. The HVS was normal and there was no bacterial growth and no evidence of infection. So looking through that brain splurge of all kind of possible different diagnoses, it looked potential to have been from the polyp. So we could then work on referring this patient forward for that. This isn't actually her polyp. This is a picture of a polyp in case someone hasn't actually seen it, but you can see the stalk and the round kind of area of the polyp, and that's particularly what we kind of saw coming down through the cervix. On the left is a small polyp, and on the right was a small to large polyps, and that was the larger polyp was the size that we could potentially see when we entered the speculum, just in case someone wanted an image of a polyp. So we then look at what the ongoing referral looks like and that plan of care for that patient. And obviously we know cervical polyps can cause irregular vaginal bleeding or discharge, but are commonly asymptomatic and often found incidentally, like we did at this speculum or smear. But due to pregnancy and because of the bleeding, the complications in the pregnancy, we did refer on to colposcopy consultant clinic, and this was completed for review for concerns, because obviously relating to delivery, because of where the polyp was coming down to the cervix, and obviously risk of bleeding and potential risk of early gestation of delivery because of the risk of that agitation of the cervix. The patient was given information and explanation of the findings, and advised at that current time not to have any intercourse, continue the laterals as a good effect from this currently, and to attend if any further bleeding or pain was experienced. The patient asked for any further concerns and further explanation required. Joint patient clinician decision was made for discharge. It's always really important that when you're making these plans that you actually involve that patient within that plan making, because they feel reassured that they've been listened to, and that they're happy that they will follow that ongoing advice and refer back to care if it's once completed. As an outcome, as I'm sure you're hopefully dying to know what happened to this lady's polyp. She was seen in colposcopy, and there was a large polyp which was greater than 4 centimeters identified, so it was quite a large size polyp. They didn't do anything about it. They left it in situ because of the increased risk of bleeding if it was removed, especially during pregnancy. Vaginal delivery was agreed, and this patient had no further issues presented in pregnancy. Obviously, cervical polyps are usually less than 3 centimeters, and anything over 4 centimeters classed as a large polyp, and is quite a rare occurrence. Postnatally, she had follow-up kind of after her delivery in colposcopy, and since the birth, the polyp was no longer evident, so it either maybe come away or it had gone back up through because of the lack of the weight of the pregnancy. And she's had no further issues of pain or bleeding since delivery, and it seems to have improved her outcomes in terms of after intercourse. So that was quite a good kind of case to go through in terms of referral through and knowing your limitations and knowing kind of where your specialities lie. So in case study 2, we're going to talk about a little bit about PIH patient. We see a lot of these come through in our triage, and not one patient can follow the same kind of rule. Every patient has to be treated on an individual basis in terms of how you treat them, because they come through with very different symptoms and very different stages of this disease. So I think it's really important to kind of take this as a supervision and then kind of make sure that we keep working on kind of how we kind of deal with them. So this lovely lady was 38 years of age. She attended triage at 37 weeks of pregnant, and she reported with sudden onset of facial edema, frontal headaches, and visual floaters, and generally just feeling kind of unwell and not quite right. The team did the ABCD approach in terms of their triage assessment to assess her maternal well-being, and the airway was patent. She was talking normal sentences. The edema hadn't affected her kind of throat or how she was talking. Her respiratory effort was normal, sacs were fine, circulation, pulse was regular, but blood pressures, obviously you can see they were quite high, so 168, 102. 155, 99, and 159, 101. The skin was warm, well perfused, and she was passing good amounts of urine, but this had 2+ of protein within it when it was dipped. She was a GCSE score was 15, but she had this onset of bilateral floaters in her eyes, and on exposure, she had noticeable facial edema, pitting edema to the legs, knees, and up to the abdomen. Her fetal heart was present, and the CHD was commenced by my colleagues in triage. She was amber scored on BSOT, so needed a medical review within 15 minutes in terms of what she got. So once again, I go into the room using my consultation methods to elicit that information from that patient, trying to find a little bit of background behind this patient to kind of help aid and diagnose and treat this patient effectively. So medical history, there was no cardiac disease or previous hypertensive disorders. She was asthmatic, but never requiring any hospital admissions, and there's certainly no issue in terms of her asthma and her respiratory rate on admission. Family history, her mother did have preeclampsia when she was pregnant, but other than that, there was nothing else with history within the family kind of genetics. Allergies, she was looked at NSAIDs that exacerbated her asthma, and she was just on a Symbicort inhaler for her kind of current medication. So using that old cart review, the presenting conditions for the onset, 1 day ago, sudden onset of that facial edema and frontal headaches with visual floaters with some mild right upper quadrant pain. The location, obviously pitting edema, lower abdomen and facial orbital adhesions around the eyes with that frontal temporal headache. The duration obviously was 1 day ago, and it had not subsided. It just hadn't got any better. Characteristics of this, she was tight, swollen, painful legs, which were bilaterally marked and pitted when pressed. This frontal headache with intermittent floaters. Aggravating factors, standing and walking distance increases swelling. Placing feet up did help some of the swelling, but never actually alleviated it completely. She tried some paracetamol, which eased the headache slightly, but never ever got rid of it. So presenting that condition, kind of with that ongoing full review, there was never any history of any long distance flight or travel, no history of any hypertensive disorders, no cardiac conditions, no report of shortness of breath. She was tolerating diet and fluid, no history of diarrhea or vomiting. The bowel movements were normal and regular, normal consistency, no history of urinary discomfort or frequency on this attendance, no PV bleeding. Fetal movements at that time reported normal pattern and strength. And the last scan at 20 weeks, she had no other scans in this pregnancy as she'd otherwise been low risk. So once again, we undertake that systematic review. What's that general kind of assessment of that patient? How she looked when she first walked into the room. She was coordinated. There was no problems with her coordination and movement. She was a non-smoker, normal BMI. Asthmatic, obviously since the age of 12, but this was well controlled by the asthma team. Abdominally, there was no previous surgery, no history of any of the IBS or lupus, and she was passing urine normal amounts, and there was no problems with the bowels. She had normal smear within 3 years, but there's nothing else really from that point of view to report. So the examination of my findings, her OBS ultimately, apart from her blood pressure, were kind of stable. She had protein in her urine, so we were obviously going to be sending that off for more in-depth reviewing. She had a MEOW score of 2, which needed that initial kind of ongoing kind of review. But a CG was satisfactory, and it actually met the Dawes-Medman criteria, or the antenatal CG criteria within about 20 minutes, so quite quickly. So I started very quickly with the neuro exam, being that the fact that she'd come in with these headaches, these kind of visual disturbances, and the fact that her blood pressure was high. I wanted to kind of get that information about that patient, kind of whether she was okay to still be in triage or whether we were looking at a developing PET picture in terms of needing to move to a more kind of complex HDU care. So this patient was alert and she was orientated. There was no photophobia at that time. There's no neck stiffness, no voice change noted. So we can move on to the cranial nerve testing. We don't do the cranial nerve 1, which is a smell test. So move on to cranial nerve 2 to 12. And these all were pretty much grossly normal kind of testing. And I'm going to break that down a little bit more in terms of the more in-depth testing that we were doing. So the pupils were equal and reacted to light in direct and indirect testing. She had a GCSE of 15. She had normal visual field acuity testing. We can't do visual field testing. We can't do acuity as we've got no Snelling chart, but vision was reported as normal. She could kind of read and she could focus on kind of phones and the paperwork around her. But in terms of a visual field, there was no blind spots or no blank spots when we're testing her visual field. She had normal facial sensation tone, no tongue deviation at that time. She had normal coordination and strength bilaterally, upper and lower limbs. She had normal reflexes and normal clonus testing. When we do the fundoscopy, it's limited due to our testing equipment. But she has symmetrical red reflexes present, and she had bilateral smooth round optical discs, and no evidence of any papilledema that we could see from what we could see. If we had any further concerns, we would then be forward her on to the ophthalmologists to have a more in-depth look at her eyes if we had any concerns about kind of that rectal damage in terms of retina damage in terms of the hypertension, if we had concerns for that. So that was kind of what we would move on from that testing. We did some abdominal examinations because she reported this kind of mildly uncomfortable right upper quadrant pain. It was a normal height gestation for baby. It was soft, non-tender to palpate. Obviously she had protein that was sent off for the relevant testing. It was cephalic, there was no scars, no umbilical hernias, light palpation, it was non-tender or there was no discomfort. And on the deep palpation, the 9 segments, it kind of once again found similar findings. There was no masses felt, there was no guard, no rebound tenderness, there was no abdominal tenderness when we had some deep palpation. So I don't think there was too much to worry about from that perspective. Cardiovascular, No signs of any underlying pathology. There was no sinusosis. There was no short of breath or skin pallor. There was no. I had to listen to the heart to make sure that there was no kind of essential ongoing concerns. There was no heaves or thrills palpable. The apex was not palpable because of pregnant abdomen. However, her radial pulse was normal, regular rhythm. No radial delay, and the blood pressure obviously was raised, so we were having to deal with that as well, and come to that. The cap refill was normal, so that's looking at that, how your body circulates out that blood, and the JVP was less than 2, so that was a completely normal finding in that jugular vein. There was normal heart sounds present, so 1 and 2, which are lub-dub sounds. There's no additional heart sounds, 3 or 4, in terms of any cardiac disease. The lungs sounded clear. There was no sacral edema, but there obviously was pitting edema of the knee and the abdomen, and the orbital edema was noted around the face. So once again, my brain splurged onto this kind of page in terms of when I'm seeing this patient, what am I thinking my diagnosis is? Obviously, alarm bells are ringing about kind of hypertension, pregnancy, preeclampsia. But it's not to kind of forget about other underlying potential causes. There could be underlying cardiac disease. Although she hasn't got any history of it, there may be an underlying issue because she's got pitting edema, facial edema, new onset of hypertension. Although the cardiac exam was negative and the bloods that were taken were all normal, it'd be unlikely. However, ECG or echoes may be performed or requested if there was any ongoing concerns antenatally or in the postnatal period. DVT or PE, that's another kind of possible diagnosis in terms of sudden edema of the legs, painful to touch, walking, but there was no history of any long haul travel. There was no evidence of DVT, and the calves were soft and non-tender, and there was bilateral swelling. There was no family history, so it's unlikely to have been this, but something to kind of maybe potentially consider. And obviously the other diagnosis would be PET or PIH, and with the protein, it's probably looking more like preeclampsia. So that would be my most likely diagnosis. She did have a raised ALT, but the plates were stable, borderline creatinine. We would obviously want to think about further investigation, like a scan, potentially if induction is not being considered, to assess that fetal growth and well-being prior to the induction process to make sure actually we're not missing a fetal growth restricted baby as well that may need a bit of extra kind of care during labour. So this is how that kind of brain splurge and that differential diagnosis can lead you through to making that right clinical diagnosis for these patients. So due to the history of asthma and being NSAID sensitive, we commenced nifedipine, initially 10 milligrams modified release BD, with a stat dose given in triage due to the level of blood pressure. She was admitted to the antenatal ward for closer observations for effectiveness of the antihypertensive treatment and for the ongoing symptoms. Scan was booked to assess the fetal growth, as it's not been undertaken for 20 weeks, and this did demonstrate a reduction in growth, and Dopplers were normal but slightly reduced lipo volume, with a mild oligohydramnios being obvious there. PET was diagnosed, and this was explained to the patient and the family the possible needs to potentially expedite the labour and induce if the symptoms or conditions become uncontrolled. On the antenatal ward, further doses of nifedipine were required to try and stabilise the blood pressure, and the blood pressure remained labile and the symptoms increased. Induction was offered at 38 weeks and 1 day, and vaginal delivery was achieved of a live male infant weighing 2.8 kilograms and the 12.1 centile, so a little baby. But blood pressure medication continued postnatally, and the patient continued on the home blood pressure monitoring, and it was being reviewed by the GP at 6 weeks for the ongoing kind of care of her blood pressure. But during this kind of care plan, I think it's really, really kind of important to, when you explain that diagnosis, having the ability to sit with that patient and explain it at their kind of patient understanding level and get them engaged with that kind of diagnosis, what they feel, what they understand, and how we're going to kind of move forward from this and treat it, was a really kind of nice conversation to have with this patient. And I think when she went to the antenatal ward, she was with the expectation and the awareness of what was going to happen next. So she felt well in control of her care, which is a really good outcome for this patient. So we're just going to run through case study 3, which is abdominal pain. And this is quite a big proportion of patients that we see as ACPs and SHOs and midwives in triage. It can be a whole host of kind of problems or concerns, from the very, very minor to the very, very major. So I thought it was a good one to bring to this day to kind of go through in terms of how a ACP who is not medical can review a person with abdominal pain, which may be non-related to the pregnancy. So obviously this patient, very similar kind of way to kind of do my reviews, because obviously this is how I do my revalidation and my supervision. But we start with that clinical presentation. She was a primate. She attended triage in her 20th week of pregnancy with sudden onset of acute generalized abdominal pain. There was no bleeding, and fetal movements at that time were reported as normal. The ABCD assessment was undertaken by the midwives. Her airway was patent. Although in pain, she was talking in normal length sentences. Respiratory rate was 18, SATs were 99. Radial pulse was a little bit raised, but at 105. Blood pressure was fine at that time, 125/78. Skin was warm, perfused, not particularly cold, clammy, hot, sweaty. And she had normal cap refill. She was A on AVPU, but the pain was reported as an 8 out of 10 and then a 10 out of 10 on movement. Exposure, there was no sign of any rash, no obvious signs of any fresh bleeding, and patient to be in pain and looking quite unwell, despite what our observations were showing us at that time. The fetal heart was present at 140 beats per minute, and there was no obvious immediate signs of placental abruption or potential risk for maternal sepsis with the normal observations. However, she did look unwell, and there was a little bit of kind of concern that actually the obs may catch up in terms of how she was looking, but she certainly looked an unwell patient. She was BMI of 37. She was 38 years of age. Because this is kind of her past medical history. She was a full-time office worker, generally fit and well, no mobility issues. She did have multiple large fibroids, which was seen at the 20-week scan. She was a non-smoker and no report of any illicit drug misuse. Negative smear results within 5 years, no previous surgical history, no domestic violence, no allergies, and no current medication. The only family history that she had was that her mother had a very late onset hypertension, but there was absolutely no other family history to note. So once again, we go through that systematic review, looking generally, and there wasn't really anything to note about her really. She had kind of normal BMI, no history of kind of glands or ENT problems, no history of any asthma, no cardiac problems, no family history of any of that either. She had no history of any UTIs. There was no previous history of cysts. We now know she had fibroids, multiple amounts in her abdomen, but she had negative smears 5 years ago and no past history of any STIs. So we kind of know a little bit of a history about her from that kind of systematic review. Once again, using my old CART kind of way to kind of look at that presenting condition to drill down to the information that we're getting. So the onset, sudden onset while we were at work, that was 2 hours ago, of acute generalized abdominal pain, just suddenly came on, bang, it was there. Location, it was generalized abdominal pain, but increasing in intensity to the right lower quadrant and the right upper quadrant area of the abdomen. The duration, it was acute pain presenting, and that just continued on that admission. It didn't really subside. It was a sharp pain starting at the umbilicus over her known fibroid location, then it migrated down to the right lower quadrant and sometimes the left lower quadrant. She did have constipation in the last 4 days, but she was tolerating a small amount of diet and fluid, but felt unwell and very tired from this pain. Aggravating factors, well, when she stood or was walking, the pain intensified immensely. And the relieving factors, lying on the bed, very, very still in one area. Paracetamol and dihydrocodone had eased the pain to a 6 out of 10 when she was lying still, but it still intensified when she moved. Treatments, paracetamol at that time, but it hadn't really been that effective. So as we know from our ABCDE, they were actually okay at that point, apart from being slightly tachycardic. She had a meow score of 2, seer reading was normal, and the fetal observations were fine. The fetal movements were felt by the mum, and there was no palpable or reported contractions. So I started with my abdominal examination. That's the first thing I wanted to get my hands on that patient to kind of work out what this pain is potentially kind of caused by, or potentially trying to drill out some of the information from that. So once again, normal fundal height. It was soft, but it was tended to palpate quite a lot in terms of generalistic kind of hands-on. Urine dipstick was normal, so that was kind of surprised, and we were hoping that it may be showing signs of kind of any kind of urine infections, but it didn't. There's no scars on the abdomen, so there's no obviously signs of any previous surgery. On light palpation, there was tenderness and generalized discomfort in all the 4 quadrants when you're palpating. Wherever you palpated, she was pain either under the palpating area or irradiating to other areas. Deep palpation in the 9 segments indicated similar findings to that, but more pain in the right lower quadrant and left lower quadrant areas. There was no abdominal distension, no garden. I would probably say when you palpate, there was a little bit of rebound tenderness, but not kind of excessively, and no percussion tenderness at that time. There were palpable masses felt around the umbilicus. We thought maybe potentially it could be the fibroids, which were located throughout the uterus and the abdomen, and no acromegaly of the organs seen. Peritoneal testing was undertaken. The rose ring sign was negative. There's no pain radiated from the left quadrant to the right quadrant when deeply palpated. However, the psoas sign was positive as it increased when we was radiating to the right upper quadrant on movement of the right thigh. So these are all signs that if there's inflammation or irritation within that the bowel or the abdominal cavity, can potentially increase that kind of pain when you're moving in specific kind of areas or specific tests that we do. It's trying to elicit out of it, whether it's cholecystitis, is this appendicitis, and all those medical terminologies that you hear. Bowels were present, their sounds were normal, there was no evidence of an ileus, and the bowels, although the bowels had not been opened, there was no diarrhea and no overflow reports of any urine stools. So, in terms of that constipation, could that be a reason for it? There's lots of different reasons. So, urine was clear, negative in testing, no current vaginal bleeding, speculum to rule out any further causes of pain. There was no visible trauma, no FGM noted, no vulvar varicosities, cervix was normal in appearance, os was closed, and there was no evidence of any miscarriage or preterm labour at that time. We obviously conveyed the findings to the patient and the partner, who were very extremely worried that she potentially could be miscarrying with this pain. And obviously we can't rule that out 100%, but at that time, everything looked like the cervix was closed and that wasn't the cause of the pain. So clinical tests required. So we cannulated this patient. We took some bloods, full blood count using these LFTs, CRPs, and amylase and group and save. We just needed a full screen to see exactly if there's any kind of cause for this. We gave IV paracetamol, oromorph, and dihydrocodeine, and we involved the MDT team as this patient became quite complex because of there's multi kind of factorial kind of potentials that this patient could have. So once again, going through the possible diagnosis, so miscarriage, we're looking at acute onset of abdominal pain. She's 20 weeks pregnant with known large fibroids, which increases her risk. She had this mild tachycardia, right lower quadrant and left lower quadrant pain. Possible masses felt because of the fibroids, but a speculum was closed and the os was closed and no fresh bleeding. So that was potentially an unlikely cause, but certainly we can look at that, revisit that if we had to at that time. UTI, obviously the urine was negative, unlikely to be an a urine infection, but we obviously sent an MSU due to the abdominal pain to make sure we're not missing that as well. Constipation, so this sudden attack of acute abdominal pain, bowels not open for 4 days. So it potentially could be a possible feature of the pain, but was this the primary cause? It was difficult to know. Fibroid degeneration would be another clinical possibility. Looking at the mass, looking at the speculums and examination we've done, it potentially would require further scans to assess the fibroid sizes and assess any degeneration. Appendicitis, we're obviously looking at in terms of pain, the examination that I've done, the positive signs that we're doing in terms of moving the legs around. So we need the blood tests, we needed a scan, and we need that MDT involvement. We weren't convinced, but we didn't know, we couldn't rule that out from the tests that we've done. And ultimately, ideally, you want to do CT scans or MRI scans and have surgical reviews. And whilst we're waiting for that, we started IV antibiotics just to kind of cover all bases, really. Could it be gastroenteritis? Possibly, but there was no current vomiting or and she was tolerating some diet and some fluids, so it's unlikely to be that. So potentially it could be a little bit of kind of three things: fibroid degeneration, could be appendicitis, and it could be a little bit of constipation, all three involved. So that's why I then referred on to my my medical team in terms of the surgical review, and that was what was requested. So a CRP was raised, went from 56 to 68. Her white cell count was raised, and her neutrophils was on the borderline, but they're at that point we're okay. The ALT was fine, creatinine was normal, MSU was fine. The scan did demonstrate multiple large fibroids, but they remained unchanged. And they were unable to assess the appendix due to the pregnant uterus, but there was no evidence of any kidney stones, no dilated renal pelvis or gallbladder, what assumed was normal appearance. So in terms of ruling out kind of other alternative issues in terms of gallstones, kidney kind of stones and bits and pieces, that was all kind of ruled out from the actual scan. Surgical team reviewed, and they queried the thought that it might be appendicitis. So they agreed to do a CT scan that was undertaken. There was no clear evidence of an enlarged swollen appendix, and they then chose to do conservative management. IV continued for 48 hours. Pain did ease, and oral antibiotics continued for 10 days. There was no obvious reason for this pain. It was possible still appendicitis, possible kind of UTI, or an infection of unknown location. Very briefly, obviously throughout the three cases that I've presented, hopefully you've seen that kind of having the ACP skills gives good ability to do that good clinical examination. Having the knowledge behind the process is so important. Obviously the ACP training has afforded me with the provision of these skills to assess these patients utilising national guidance and formulate ongoing care plans. CKS NICE guidance and the RCOG obviously can formulate and give you those plans to kind of work your way through, so you're not going in blind. And I think it's really important to know that when you are undertaking these reviews as an ACP, to utilize the CKS NICE guidance in terms of that differential diagnosis. Sometimes it just throws up a question of, oh, I never thought about that. Let me see if it could be this. How do I test for that? And it gives you the kind of the answers in terms of doing that, so that you can then give that whole care and that holistic care to that patient without missing a potential kind of thought process that you may not have thought about. Obviously, MDT working is imperative to ensure best care and outcomes. And every day remains a school day, because every day patient presents in very, very, very different ways. And it's utilising the knowledge base that I have, but also of my colleagues, to get that best outcome from that patient. I just want to, this is a recent case study that I've had, and I just wanted to kind of present it very, very, very quickly with talking about reviewing ongoing reduced foot movements and ultrasound reviews for this, because ultimately I do this a lot in my role, and I think this particular case demonstrates how having the ACP there in the triage kind of maybe 4 or 5 days a week provides a continuity to these patients that are representing all the time. You get to know that patient, you get to know that patient's history. They feel listened to because they know you, and they haven't got to keep going through their same history over and over again, which is a big thing for patients. They want to know that you know them, and having the ability to have continuity with the patients that I see is such a privilege. Especially in a high risk kind of areas as in triage, because the turnover of patients is so quick. To actually develop a relationship or have that continuity with the patient is, like I say, a real privilege. And this case hopefully demonstrates that a little bit more. So this lady she had a BMI of 41. She was 39 years of age. She was a primate, natural conception. She did smoke, but she professed to only smoke maybe 10 a day. There was no history of hypertension, no risk factors for diabetes, no DPT or PEs. Medication, she was on aspirin because of her BMI, and that was until 36 weeks as per our hospital policy. And she was also on sertraline for history of anxiety, depression, but her mood was currently stable and there was no concerns. So during this pregnancy, she had multiple presentations from around about 28 weeks for concerns of reduced fetal movement pattern. She would present maybe a couple of times a week, and in between that, baby would be moving fine, and then she'd re-present. She'd had serial growth scans, and that was already booked because of her BMI, but we didn't do it just from 32 weeks, we did it from 28 weeks because of the ongoing presentations for reduced fetal movements. And we did this every 4 weeks in line with the policy. So from 28 weeks to 36 weeks, all demonstrated normal growth, like Dopplers, and baby was plotting around the 25th centile on the IG21, which is the Intergrowth 21 charts. Patient always reported to feel well, no concerns of preeclampsia, no PV loss, and no abdominal pain. Blood pressure when testing ranged between 120, 140, 75, 89. Her booking one was very similar, 120, 78. And there was never any protein at that time to worry about. CTGs were always normal in categorization and met the computerized CTG analysis, and the STVs were always greater than 5. But at 37 weeks and 6 days, she attended again with increased concerns regarding fetal movement pattern. She reported very little movement felt in the last 12 hours with no pain, no PV loss. She had a little bit of a mild headache, a little bit of facial edema, but no other symptoms of preeclampsia. Her blood pressure was 140/88 with a plus of protein, but her bloods, when they were taking them, were normal. The CTG didn't meet criteria at that time, but the STV was greater than 5, and there was only 3 movements felt during the CTG. CTG was decided once we reviewed it, because obviously when anything doesn't meet criteria, the ACP or the registrar reviews it and looks at the whole kind of case holistically. CTG was repeated within a 12-hour period, probably a little bit sooner, and it then met criteria as fetal movements had improved. However, in view of the maternal concerns, CTG not meeting criteria, another scan was requested in the interim, just to kind of have a look at kind of that fetal well-being and assessing that. So the scan was booked the following day with repeat CTG if reduced fetal movements continued. The scan was reviewed in triage. It demonstrated a very slight tailing in growth to around the 15th centile on the Intergrowth 21 chart. There was normal liquid Dopplers reported, but the UA, when you looked at the chart, was on the upper limit and the MCA was on the lower limit, and the CPR value was below the 5th centile. The patient was reviewed and sent home with a plan to repeat the scan in 2 weeks to assess ongoing growth and to monitor fetal movements and return if any concerns. When I returned from a day off, I wanted to follow this patient up, as obviously I'd requested the scan. I had known this patient throughout her pregnancy from 28 weeks, so I was interested to know and make sure the scan was normal. So I looked at the scan results, and it'd been noted that the chart had obviously, when it was charted, that it had been told that it was normal like in Dopplers, but actually the CPR value was kind of off the chart. So we needed kind of a further scan sooner than 2 weeks. So I arranged another repeat scan that same day to assess that CPR value, or I spelled that wrong, sorry, the CPR value and the fetal well-being, and just followed with the patient to see how she was feeling in terms of any preeclamptic symptoms and how she was, if she had any further concerns about baby's movements. So I did a bit of a follow-up call and arranged that scan. When she came back, her CPR value was still the 5th centile, and it was less than 1. The Doppler had become abnormal, and the UA Doppler had been above the 95th centile. So I was more concerned about kind of fetal growth restriction being a potential cause of reduced fetal movements, but also that there was a little bit of brain sparing going on in terms of how that baby was tolerating being inside the mum, basically. I discussed with the consultant in view of the scan results. and the reduced movements, which remained a concern. And obviously, we agreed that an induction was to be offered. And we discussed our concerns and scan results with the patient, and she was obviously very concerned about the baby's movements changing, and she was happy with the induction of labour that was being offered, and was quite happy to undertake that. During the labour, she developed a little bit of hypertension, which I kind of feel was maybe coming with that borderline hypertension starting in the latter stage of a pregnancy. She required antihypertensive treatments, and protein within kind of her starting the induction process became up to 3+ the protein. She did actually have a spontaneous vaginal delivery, but obviously because of the Dopplers, we did discuss modes of delivery with her, but she was very keen to try for vaginal delivery, so we supported her with that, with acute awareness that with a baby with poor CPR value may end up increased risk of cesarean section. She had a Nell infant that was born the 8th centile, was clearly a little bit fetal growth restricted, but he did really, really well. And she was discharged home on day 3 after further blood pressure issues postnatally, but we had to get her started on some correct medication for that. So generally, I think she was probably, it was a bit chicken and egg. Was the placenta, or the fetal growth restriction, the reduced fetal movements, starting a preeclampsia, or was the preeclampsia starting with a fetal growth restriction? Either way, there was evidence that there was kind of an issue going on. But so in summary, I think that kind of case can kind of really highlight the importance of having that kind of continuity to that patient, knowing your patients and that wanting to know what's happening to them, follow them up, because actually that potentially could have been missed. And although the scan said everything was normal, when you looked at the actual scan with more, intensity, what happened was I think they clicked the wrong button in terms of saying it was a normal kind of Doppler and not the right one. So very, very quick glance, everything's normal. She can go home and repeat the scan in 2 weeks, which wouldn't have been the wrong decision had it been the right Doppler result on there. So having that ability to follow the patients up, have that continuity and have that understanding behind those patients really was evident in that case in terms of being able to expedite that baby's delivery and also then achieve kind of a good outcome for that mum and that baby. The ACP and triage can obviously review, we can refer, we can assess patients with all the presenting conditions, knowing our limitations, knowing our role and expectations, and knowing when to refer on to someone who may have that more greater understanding of the condition that you think it could be. We build good patient relationships and knowledge, aiding the patients to feel listened to and feel like they're known to us when they represent back to us. Having that patient oversight and being core in the area enables improved holistic reviews and patient-centered care. And the last case highlights knowing your patient and follow-up can have that positive outcome. Maximising the midwife's capabilities and experiences through training and not trying to be the mini doctors and trying to not blur those lines is so, so important. But with the capabilities and the experience through the training, you can certainly undertake those reviews effectively. And I hope that you can kind of see from those kind of supervision kind of reviews that I've done that that you can happily go through the case reviews with them. And then obviously referring on for second opinions with medical college is a daily event, if not an hourly or 5-minute event, to make sure that we're making those right reviews, right decisions for those patients, because ultimately patient safety is our first and foremost when we're undertaking any care for these patients. Any questions?
Thank you, Sam. That was brilliant. I was following along and I was thinking, I was going through all the differentials in my own mind and then going back again. So yeah, I really enjoyed that. I think Ashley's going to come on as well and answer some questions with you. At the moment, we don't have any specific questions. They're starting to come through. So if I ask the questions to Ashley that came through before, so there were a couple of comments. Somebody said, Ashley, did you get your study published, or are you considering having your study published?
I haven't yet got it published, but it's definitely something that I want to do in the future. I think that any kind of study that we're doing around ACPs in maternity services, we really need to try and push to get them published, just to build that pool of evidence and awareness. So yes, definitely, it's definitely in my plan.
Excellent. And also, and this is a question for both of you, really. As midwives, we are used to being autonomous practitioners when it comes to low risk midwifery or maternity care. How did you find the mental transition into becoming autonomous practitioners in complex care?
Shall I take that first?
Yeah, you go, and then I'll, yeah.
I think through support and having the backing of the supervisor when I was training kind of helped really kind of that transition. I really feel, you know, going through the training, and when I was on the ACP course, I think they give you a lot of support, education to help that transition happen. But yeah, I don't really know how else to answer. I felt fine doing that. I'd been a high-risk midwife in the triage for 7 or 8 years. So actually that was my bread and butter of seeing those patients anyway. So it was just, for me, the natural next step on to be able to kind of see these women through their care in triage, rather than kind of stopping from the normal or normality perspective.
Thank you. Ashley?
Yeah, I think I would definitely agree. I think that transitioning from a trainee to a qualified ACP during the training year, it's still very much, although you're becoming this autonomous practitioner leading high risk care, you're still very well supported, and I still feel very well supported in my current role, that if, you know, knowing the limits of where my competence is, and continuing to build those, has made the transition quite simple. And like Sam, I've always worked in a high risk setting, so actually that's probably a more familiar environment for me.
Perfect. And then there's quite a few comments just saying, thank you, Sam. Thank you, Ashley. Great presentation, Sam. Thank you. That was really interesting, Sam. And then there's a question here that says, if you were to suggest one specific educational need for general triage midwives who want, what would that be? Clinical history taking, for example.
Yeah, so if I could advise anybody to do a little bit of training that has really helped kind of underpin my knowledge of everything, in that would be taking, I mean, I don't know, different universities do different training things, but mine was specifically the history assessment and practical examination course, so the HAPPY course. It in-depthly talks to you and teaches you how to undertake a consultation, looking at consultation models, looking at how to elicit that information from a patient that comes in saying they've got everything wrong with them and you can't look at the wood for the trees. How do you get that important information out of somebody? Often, I often say this about when I was working in triage alongside the doctors. You go in and take a history from a patient, you come out and go, this is what's going on, this is a history she's given me, she's got abdominal pain, da 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 da. The doctor go, lovely, I'll go in, take a history, and they come out and they go, oh, well, she's got this and she's got that. You're thinking, I'll just answer those questions. How have you got different answers? And it was that kind of gave me that, oh, why are they getting that information that's different? What are they asking that I'm not asking? And sitting with them and going through their examinations and doing this course, that HAPPY course, really gave me that insight, thinking it's not what we ask, it's how we ask it. It's how we ask those open and closed questions. Open it when you want them to kind of elicit more information, and close it when you have more detail. So if I could tell anybody to do something to improve their ongoing practice to help that patient care, do a history of taking assessment and examination course, because it is such a good course to go on in terms of basic examination skills. That helps.
Thank you. Do you have anything to add, Ashley?
No, I would completely agree. So our history taking was within our health assessment module, so it was looking at the kind of the history taking and then the assessment as well. And having been a direct entry midwife, I didn't have the background. You have the basics, I'm sure, in the first year of midwifery, but the medical general side of it, and it massively helped, because now when people present with things which before you'd say, oh, I'm sure that's just ligament pain, there's lots of other things going through your mind that, oh, it could be this, and this is what I need to exclude. So, but as Sam said, the value of being able to take a real comprehensive history is definitely something to start with.
Perfect, thank you. And then I think one last question before we go to lunch, and somebody's asking, in preparation for or as part of the training for ACP, did you undergo a course about the common conditions that women may present with?
I think during the course, you kind of, during that history taking and practical assessment, you look at all the common conditions, not necessarily pregnant women would present with, but anybody could present with. So I did my course with nurses, paramedics, multidisciplinary training. So we did it as what people could present with abdominal pain, what that looks like, and how to elicit that information, how to kind of assess that. Someone comes in with shortness of breath, what could that be? So not just in pregnancy, but the course kind of gave you a much more wider generalistic approach and wasn't just midwife specific, which I think benefited. Being a direct entry midwife really benefited me to kind of get more of a general kind of viewpoint on kind of health conditions that we may not have considered in our role, because we assume our women are healthy women, but they're coming through with much more kind of complicated conditions now. And to have that awareness and have that training within the course was really kind of crucial to kind of enhancing my knowledge. And also then spending time with the medical team across the main trust or in ED kind of opened your eyes a little bit more in terms of other conditions that potentially things could come through.
Yeah, and I think that when I started the health assessment module, I was thinking, right, by the end of this, I'm going to know every single possible presentation that could possibly come through the door, and I'll know what to do with it. And that quickly became apparent that wasn't going to happen. And like Sam said, on my course, there are nurses, there were quite a few paramedics who just seemed to have so much knowledge. But actually what we were taught were the red flags and what was normal, what was not normal. And if we then couldn't elicit exactly what was going on, we knew what investigations we needed to do to find out what was next. So, and I think your knowledge, I think sometimes you get all of this knowledge and you surprise yourself sometimes and think, oh, actually I do actually know what's going on. So although it seems like you can't possibly learn it all kind of comes together, and it's more the tools of investigation rather than knowing every single possible presentation.
Absolutely.
Thank you. I would agree. I would say one of the best parts for me when I did the clinical assessment module as part of the ACP was that multidisciplinary training, because there were a large group of mental health nurses, that were undertaking it at the time. And I learned so much from them about taking mental health assessments and how to ask the right questions quickly, and how they go about doing things in a timely way. And yeah, I think you learn a lot from just being with other professions, but also the main thing that you learn is where to look things up. So like you said, whereas at first you think you're just going there to be taught the specific conditions, actually the most important thing you learn is how can I quickly find what I need to learn or what I need to know in this situation. So yeah,